Good afternoon, everyone. My name is Ian Culbert. I am the Executive Director of the Canadian Public Health Association, and I'm very pleased to welcome you today to today's webinar on Canada's public health system. We're very pleased to be co-hosting today's webinar with the Public Health Physicians of Canada. So very quickly, just a little commercial about your hosts. CPHA is a national, not-for-profit, non-governmental organization representing the public health perspective on a wide range of issues. At our heart and soul, we are an advocacy organization and take on a number of issues that are relevant to the public health community today. Marijuana legalization and regulation being one of them that we're very busy on these days. As mentioned, we're also very pleased to be co-hosting today's webinar with the Public Health Physicians of Canada. This webinar series goes throughout continues until next April on a wide range of topics. So if you enjoyed today's presentation, hopefully you'll come back for ones in future months. Keep in mind that all the webinars are recorded and are available to members on our website. So the first thing we're going to do is do a little poll to see who is participating today and where exactly you're from. So you should see a poll on your screen right now. If you want to take a moment and vote, that would be great. Okay, super. So we have quite a few from Ontario, but an interesting cross-section of people from across the country. So we're also interested in seeing getting some more information about our participants today. So can you tell us, are you a student or a trainee, or what your current background is? Super. So once again, a good cross-section of people from different levels of study. Okay, and then we'll move along to the next question, which is, are you a member of either CPHA or the Public Health Physicians of Canada? Super. Well, that's a good snapshot. Glad to know that we've got some members actively involved in today's webinar. So as we switch back, so just a quick primer on how the webinar technology works. While you can listen in on the conversation today and the presentations, all of your lines are muted. But if you want to ask a question or have a concern of any kind, just type your question or your message into the chat box, which is located in the lower right-hand corner of your screen. Everyone will be able to see that. If you want to direct a specific question to a technical question to CPHA, you can send a private message to CPHA webinars. But if you have questions, please include them in the everyone chat box so that everyone can see the questions. You have some other options. You can agree or disagree. You can ask speakers to speak louder or to slow down or what have you. And those symbols are hidden under the drop-down menu where the little person is holding up their hand or swearing an oath. I'm not sure what that person's doing, but you get the picture at the top of your screen. So that is the technical briefing that you get today, and hopefully that will get you through. Just a reminder that it is the webinar is being recorded today and will be available on the member portal shortly after the session ends or later this week. So I am very pleased to welcome today's moderator, Zhao Hu, who will take over from here. Thanks very much, Zhao.
Thanks very much, Ian, and thank you everyone for joining the webinar. I apologize, I'm a bit sick, so if I start coughing or hacking away, everything will be okay. But without further ado, I will introduce the speakers. So we'll be starting with Dr. Ak'Ingabe Guyon. She is from Montreal and currently works at the Montreal Public Health Unit. Her main interests are around healthy public policy, public health systems, and general public health practice. She has extensive experience around the world, including in multiple regional and provincial Quebec public health institutions, rural and urban British Columbia, East Africa, England, and Denmark. After Ak'Ingabe, we'll be moving westwards to Dr. Sandra Allison, who is the Chief Medical Officer for Northern Health in British Columbia. She's a public health physician and is responsible for all public health programs in Northern Health, and she advises the Northern Health executive team and the board on issues of importance to the health of Northerners from British Columbia. And then lastly, we have Dr. Michael Rachlis, who is a public health physician and practices as a private consultant in health policy analysis. He is consulted to the federal government, all 10 provincial governments, and 2 royal commissions. He has also made presentations to committees of the Canadian House of Commons and the Canadian Senate, as well as the U.S. House of Representatives and Senate. Dr. Rachlis is an adjunct professor at the University of Toronto and the lead for policy and communications in the Public Health and Preventive Medicine Residency Program at University, where I am. Great. So we have some very, very well experienced speakers with a diverse array of backgrounds. So I will let Dr. Ak'Ingabe Guyon start. Just a reminder, if you have any questions, please just type them in the chat box, and I'll sort of be collating those questions as we go along. And after these presentations, we'll have a chance to ask those questions to the speakers. So go ahead.
Hello, so this is Ak'Ingabe. I don't see the slides appearing. I guess they should be appearing. But in the meantime, I'll just say that I'm speaking on my own behalf. I'm a public health and preventive medicine specialist in Montreal, and I'm also an assistant clinical professor at the School of Public Health. I'm not speaking on behalf of Montreal Public Health. So that's for the non-disclaimer. Over the next few minutes, I'll just state what is a public health system, or what are ways to understand what is a public health system. And then I'll dive into the Quebec public health system and give you some highlights and a summary of how it is structured. And finally, do not fear. I have more material at the end of my presentation that we don't need to go through, but that will be there for you. The slides will be available afterwards if you're curious about some elements that I've mentioned. So let's start by just reminding ourselves of, with a big picture of what is a public health system. Often we focus on who employs us, i.e. the Provincial Ministry of Health or the regional or local public health units, or sometimes the federal health level. But let's remind ourselves that there's also on the left-hand side the private sector, NGOs, or the academic sector, who are also key elements of a public health system. If we now go to the Quebec public health system, you most likely know that Quebec is almost one-fourth of Canada's population. And over the last few decades, many observers have said that Quebec had the most comprehensive public health system in Canada and the most vigorous one. And here is some objective data from a CIHR report in 2003 entitled The Future of Public Health in Canada, where it stated why it was felt that Quebec had a very strong public health system. It has a modern comprehensive public health law that was enacted in 2001 that includes health impact assessment and a health in all policy approach. It has clearly articulated core functions. That means that since 1997 there have been documents, standards that really define what is public health in Quebec, and also increasingly, and now certainly, that these documents are stating what are the expected activities at each level of the system. There's also a Provincial Public Health Institute that has a comprehensive mandate that works over all the functions of public health, and that's the Institut National de Santé Publique du Québec. And in Canada, there are 3 such institutes, the BCCDC, Public Health Ontario, and the Institut National de Santé Publique du Québec. Then Interestingly, there's public health involvement at the senior governmental level. So the Chief Medical Officer of Health is also an assistant deputy minister. And that's interesting, and that's certainly useful. There's explicit encouragement for intersectoral partnerships. So public health is not confined in Quebec to the conventional health protection sector. We're also explicitly entitled to interact with the municipal sector, the school sector, etc. And there has been very strong workforce development, and one example of this is that almost 40% of physicians specialists in public health in Canada work in Quebec. So if you need to know more, the references below will be of use, certainly. If I give you a summary of how the public health system, and I'm focusing on the public sector, the institutions of public health at the provincial or regional level, this is a summary of how Quebec is structured. So its governance structure is really mostly regional, and that's in opposition to other public health systems in Canada, where in Alberta, for example, the public health system is really a centralized Alberta Health Authority, and from there, public health is deployed. In other provinces, in Ontario, as many of you know, public health is housed in the municipal or local level, even though I know this is changing or evolving. In terms of structure, so there are 18 regional public health units, and there's also one provincial public health office or direction. There's this expertise center, the Institut National de Santé Publique, and most of public health frontline activities are offered through the healthcare system, through what has changed over the last 2 years, but they were regional health authorities, now they're territorial health authorities. But basically, a lot of the immunization, for example, or preventive dental care is offered through the healthcare system at the local level. Some highlights, and I've gone through many of the highlights in the previous slides, but I'll focus on the last two highlights. There are multiple inter-regional consultation networks, and this is an invisible aspect of the public health system, but to me, I've been working in Quebec for almost 10 years as the equivalent of an associate medical officer or a medical consultant in public health. This is one of the aspects of the strength of Quebec that is not often visible, but there are consultation tables around environmental health, infectious disease, surveillance, health promotion, disease prevention that unite each key person from each region, along with one person from the province, the provincial office, and one person from the INSPQ, the Institut National de Santé Publique. And that's been really helpful for crises and between crises when we just have to operate and have a coherent public health offer in Quebec. And I've already mentioned that a good chunk of the capacity in terms of public health specialists, medical specialists in Canada are in Quebec. Some elements, some highlights in terms of public health interventions, and that's just to give you a sense of how it can be different in your own jurisdiction. One particularity in Quebec is that occupational health is also part of public health interventions. It's not only workers' compensation boards that deal with occupational health. Another particularity, and that's in opposition to Ontario, food inspection is not part of public health interventions in Quebec. And then finally, in terms of environmental inspection, I know that in many provinces, public health has a big role in environmental inspection. In Quebec, it's quite a limited role. This role is devolved to other ministries or departments. Something very big and very brutal happened in 2015, and that's how unfortunately, that's how I have to end today, this overview of the Quebec public health system. 33% cuts to the Quebec Regional Public Health Network. This has been a brutal, unexpected cut. We saw it coming in 2014 because it was alluded to by the minister. It was never justified other than by saying it was part of austerity measures and the government having to have good finances. And what this has meant practically is in this illustration. So before 2015, Quebec was really a three-tier system in terms of its public health and in terms of its healthcare system, and public health being part of the healthcare system, this is where public health was. And these are the green, if you look at the green spots in the left-hand column, you'll see where public health was. So there was an office of the Chief Medical Officer of Health and Direction Nationale de Santé Publique at the Ministry of Health. There were 18 regional health authorities where the regional public health units are. And there were this frontline healthcare level, those 95 local health integrated centers also had public health teams. And the size of the circles are meant to represent the size of the budget. So 25% of the public health budget in Quebec really goes to regional health authorities, and 75% of the budget goes to local health frontline public health activities. What has happened in 2015, and that you'll see in the green circle at the equivalent of the regional health line, is that the regional health authorities were cut 1/3. And that's huge because this is where the professionals who are the most trained in public health reside in the system. They also work at the ministry level, and some work at the local level. But most, for example, of the capacity in terms of public health physicians is at the regional level. Most of the people who have masters or PhDs even in public health are at the regional level, and this is where the system was cut. And on top of having a cut, there was a major healthcare reorganization that also was criticized as being very brutal and not necessarily evidence-based, but the whole regional local level was reorganized in territorial health authorities. So I won't go into the turmoil that this has meant, but I'm open to questions or comments at the end. Some lessons being learned through all this, and we'll have time for discussions or during this webinar or after. There are similar challenges across Canada. There have been unfounded or arbitrary reforms across the country in public health. This happens. Public health independence is always in need of protection, and there are many ways to attack public health independence, and that's a way to see it is that public health independence can be attacked either by cuts or by firing chief medical officers of health or by not positioning public health in the right management levels. We endured cuts. And a lesson being learned is that I'm convinced that we always need to be more visible, and our successes need to be more visible. In finishing, there is hope. There must be hope. Pendulums do swing back, and some elements of hope. There have been very strong citizen and professional movements who were born out of these brutal cuts. And I invite you to go to these websites or to the CPHA presentation that talked about the birth of those citizen and professional movements in Quebec, stating that public health is important and taking very public stances against the cuts. There is hope. The case of Ontario is in some way a source of hope for me. Ontario did reinvest in public health after Walkerton and SARS. I'm hoping that we won't need a crisis in Quebec in order to have to reinvest in public health. There is extraordinary know-how and public health expertise in Quebec and across Canada, and I see among participants some of you that I've worked with, and you're part of that extraordinary know-how and public health expertise. And maybe a last word is that your future research on public health systems can really have great impact. For now, we have very sketchy bases in order to stand up front and say, when you invest in public health, in the system of public health, these are the outcomes that you get. This is how you can deliver good interventions if you invest that much money. We have some data, but not that much. So that's for now. As potential questions, and Gia saw them before, so he and Michael as well, so they might be using them afterwards to animate the discussion. But these are some questions that we may ask ourselves, and I'll just point to you some the references if you're interested in delving into all this. Appendix, just public health systems and where the data is and isn't in Canada currently. The history of the Quebec public health system, features of high-performing public health systems, and that's a preview into an article that will be out in the coming week or so that we've published in the Canadian Journal of Public Health. And finally, the advantages and disadvantages of having public health within health authorities. So thank you, and I'm very interested to hear Sandra and Michael.
Thank you very much. It's Sandra Allison. I believe, Gia, you're going to put my slides up.
I think Emma will be.
Thanks very much. So Sandra Allison, I'm Chief Medical Health Officer in Northern Health in British Columbia. I live and work in Prince George, BC. And so I'm going to walk you through public health in a rural health authority in British Columbia. So my objectives today are to describe the structure and function of the public health programs within my regional health authority, and I will situate Northern Health Authority and our functions within the public health system in British Columbia. And then I'll touch on unique opportunities and challenges of rural public health. So Northern Health is the top 2/3 of the province in the province of British Columbia. Our health authority is one of 5 regional health authorities. The geography of Fraser and Vancouver Coastal and Vancouver Island Health are a little bit complex, but you can see the color coding on the map. And Interior Health is my rural counterpart to the south. In northern British Columbia, Northern Health Authority being the very light blue health authority in the upper left-hand corner, we're the least densely populated health authority within the province of British Columbia. Our population distribution is reflective of a younger, more developing population, not an aging population. It's fairly squared off. We do have a very large land mass, around 620,000 square kilometers, and we serve about 288,000 people. Our population is approximately 18% Aboriginal descent, and our First Nations people live all across the north, and about 60% of them live in our urban centers. Of interest is we have a birth cohort of around 3,400 children born every year. We have over 80 continuously inhabited First Nations communities in northern BC. That's representing about 54 distinct First Nations, and we work in partnership with over 30 municipalities. We do organize ourselves in what we call health service delivery areas and local health areas, and that's how we use our data. But really we do work as a seamless, or attempt to work in a seamless way across the north. We do also work in partnership with school districts, RCMP districts, regional districts, and regional hospital districts. Going back to how we organize ourselves and compare ourselves, within the province there is a tendency, and within most provinces, to compare north to south, but our populations being so distinctly different to the southern cohort in the province, we do encourage comparison amongst the Vital Stats Canada peer groups that were prepared, and so our peer groups are far more similar to populations in other northern, rural, and remote settings. In Northern Health, we are governed by a board, and so this is a standard governance model. The board directs the CEO, and the CEO directs the senior executive team, of which I am part. I also function as a manager, or an accountability manager, for public health programs, and I'm not called the Vice President of Public Health, but I do function in that capacity. And under my leadership, I guide the work of the population and public health portfolio to fill the functions of public health that are the traditional functions of disease prevention, both chronic disease and communicable disease prevention, preventing injuries, both intentional and unintentional injuries, promoting health in settings and with targeted populations, protecting health in the legislative aspect. We'll cover some of these functions in another way, as well as assessing the needs of the population and preparing for emergencies. The population and public health portfolio under my leadership has 3 streams of work and a few other areas of work. In the protection unit, the preventive public health unit, and then the population health programs are regional programs that serve the entire north. I also have a surveillance program that's just building, and I have medical health officers that work closely with the program areas. In the public health protection area, the true sense of public health inspections that we call public health inspectors in the province of BC environmental health officers, and they fill the role of ensuring air, water quality, food safety, personal service establishment safety, and they do enteric disease investigations. They're also involved in other activities related to healthy built environments, and certainly other ways of engaging with our communities. We also are responsible for licensing in the province of British Columbia, and this was unique to me on my transition from Manitoba. So we are responsible for the care and safety for individuals living in our residential care facilities or people attending daycares or other group home settings. In the north of British Columbia, we have a significant amount of industrial development, and so I have one area of work in the north that is diving into the effects of effects on health of resource development, and so it's a very interesting area of work and unique to the north for sure. Under preventive public health, we're responsible legislatively for the communicable disease control functions, as well as all areas of public health nursing. This is not an entirely inclusive list, but their functions are along the lines of our traditional programs of immunization, healthy child development, including prenatal programs to school-aged children in our schools, and comprehensive school health, sexual and reproductive health, and harm reduction. The third area of work is related to the population health programs, and we have organized ourselves to address individual risk factors and mitigating individual risk factors in the areas of tobacco, physical activity, healthy nutrition, mental wellness, and injury prevention. As well, we are focusing our efforts to address community development at a very grassroots level with our local committees, addressing healthy public policy with our municipalities, and in close partnership with our schools to address comprehensive school health. Other areas of work are including the surveillance and reporting functions, the medical health officers, and the public health emergency preparedness. All of these functions are meant to fulfill the functions under the guiding framework for public health in British Columbia. And I used this as a resource when I was in Manitoba, as I found it was an excellent way to characterize all the areas of work for public health. And the framework obviously was put together by partners at the ministry, including our provincial health officer. Another guiding framework that gives us some background and structure to guide our programs is our chronic disease prevention framework, which is the Healthy Families BC policy framework. And I won't go into great depth in these, I only have 10 minutes. Regarding the system, though, we do have ministry partners, and so the ministry, and this is a complicated ministry, is that there, through the Premier to the Minister of Health and a number of deputy and assistant and associate ministers, provide the core functions of emergency management, healthy living and health promotion, which are the core areas around tobacco and physical activity, health protection in the sense of health protection, and public health services, which is in general, the preventive public health functions, as well as the surveillance function. We do have a number of health partners in the province, and I mentioned a few of them already, including the Ministry of Health, the Office of the Provincial Health Officer, which is Dr. Perry Kendall, and the 5 regional health authorities. But I would like to also mention our sixth partner, which is the First Nations Health Authority, formed in 2013. And they are a health authority that's provincial and responsible for the First Nations communities. And we're building our partnerships as they grow as an organization. Another partner is the Provincial Health Services Authority, and it's worth mentioning that the Provincial Health Services Authority has agencies as well as programs and services. And so the BC Centre for Disease Control is an agency that we connect with in public health most frequently, as well as Perinatal Services BC. But there are a number of agencies that we can connect to if we need them as a resource. Under the programs and services at the Provincial Health Services Authority, we do connect with a number of other partners working there, including the Occupational and Health Safety Services, Health Emergency Management BC, PICNET, or the Provincial Infection Control Network, and then the Population and Public Health Unit at the Provincial Health Services Authority. At the BC Centre for Disease Control, they have a number of services that we access, the experts and the expert consultation through TB, STI, HIV prevention and control programs, as well as the hepatitis program, accessing the experts related to communicable disease and control services, as well as some functions under public health emergency management and environmental health and immunization programs. The BC Centre for Disease Control also has a number of resources, and I always guide people to both the manuals for immunization and communicable disease control, as they're excellent resources, and the data and reports are also very excellent. Within a northern and rural setting, in my health authority, we do have distinct rural public health opportunities and challenges, and I'm going to just reflect on the tier groups. And so within northern British Columbia, I have the Northwest Health Service Delivery Area and the North Interior Health Service Delivery Area. That's a mouthful. And both of those areas are far more similar to areas within Manitoba, the Parkland area, mid-level in Saskatchewan and Western Ontario and across Quebec and Labrador. The Northeast Health Service Delivery Area resembles the Northern Alberta context much more similarly, and we see that in our resource context. It looks very similar to places like Fort McMurray. The opportunities in the north are amazing, and we always are outside and reflecting on our opportunities to get out into nature and to access culture in our many settings, and that's an excellent opportunity. It's very rare a day goes by without seeing some wildlife and taking in amazing views. But there are challenges, and the CIHI report from 2006, How Healthy Are Rural Canadians, really did an excellent job in demonstrating how geography and weather, health, human resources, and recruiting and retention, service allocation in a large geographic area, and funding models really do impact patients' access to preventive and diagnostic services and providers. The outcome is that individuals present later in their disease and often have worse health outcomes. The determinants of health, including lower incomes and levels of education, are quite prominent in rural and remote settings. And we do see that in a cascading impact on health behaviors and health outcomes, resulting in higher overall mortality rates. And so that's something that we know is evident. In Northern Health, we recognize this, and we're trying to address this in a rural primary health care model where public health, home and community care, and mental health and addictions are provided for within a patient and family-centered setting. Addressing priority populations of the early child development, the frail elderly, those with chronic diseases, and mental health and substance use. And the vision of primary health care in Northern Health is really to shift our services so that we're able to provide holistic, cradle-to-grave, full-scope primary health care in a person and family-centered manner, using generalist community health nurses, practicing to a full scope of competency, supported by interprofessional care teams and specialized programs facilitated by technology to help us with that huge geography. Embedded within healthy communities, we recognize health promotion happens at the ground, applying an equity lens on all that we do, and focusing on improving population health. So I believe that was my last slide. Thank you very much for listening.
Thanks very much, Sandy. Michael, you ready?
Michael Rachlis. I'm hoping. Ja, it's Michael. If you can hear me.
Yeah, we can.
Great. Should I just go ahead then? Thank you very much.
Yeah, why don't you go right ahead? Yeah.
Thanks so much to Dr. Guyon and Dr. Allison for talking about their jurisdictions. And I'm not going to go into nearly all the details of how every province is organized, but I was going to give you a little bit of background to why we have some of the disparate structures that we have and then lead into the discussion. So if I could have the next slide, please. The objectives of this are to have a greater understanding of the structure and organization of public health systems in Canada. And next slide. So first of all, I think we need to talk about what is public health. Next slide, please. And while you're reading that, I'll just mention in the background that, as each of you noticed, there are some significant differences between Quebec and BC's public health systems. In different ways, they're seen as sort of leaders in the country. And Ontario also has a system with a fairly strong central support, different delivery model. But public health is really designed differently everywhere in the country, and then differently in different parts of the world. And this is from the Public Health Agency of Canada, which takes more or less a definition that John Last had codified from others that public health is the organized effort of society to keep people healthy and prevent injury and premature death. Won't read it all. Next slide. You'll see, however, that just looking at this slide for our neighbors to the south, that public health in the United States, it looks like it is both more and maybe less than what it is in Canada. Starts off by saying that public health connects us all, which seems to be a very strongly organic view of public health, that sort of the greatest public health advocate with a very broad view of public health would connect with. But then as you go through the definition and you get into the last line, that you see, the last couple of lines, you see that there's a real strong connection with the health care system in the way that public health is conceptualized. And the last sentence is, a large part of public health is promoting healthcare equity, quality, and accessibility, which is an extremely strong function of public health in the United States, because it historically has been responsible for the healthcare, medical care for people who are medically indigent, could not afford care. Next slide, please. But there is also a difference, therefore, between the concept of public health, I think, as best expressed in that Public Health of Canada definition, the organized efforts of society, and formal public health services, because in each jurisdiction in Canada, public health services are organized differently, which is the expression of both somewhat different values in different provinces, but probably more likely just historical differences in time, and in particular more recently when healthcare services have been reorganized, as they were in Quebec recently. Those are tied to reorganizations within the healthcare system. And next slide, please. So the Canadian jurisdiction for public health is shared between the federal government, the provinces, and increasingly Indigenous peoples. Canada, it's not, I think, generally well known that most countries, even though they have provinces or states, are not true federations. In other words, that they may have organized themselves because the federal government has developed sub-national boundaries for better organization of local services. But the constitution for the country actually only creates a federal government, which then writes legislation about how these subnational units might be organized. Canada is one of less than 25 or so true federations, like the United States or like Germany, but for example, not necessarily like the United Kingdom, and certainly not like France, where they're within their sort of scope of jurisdiction, the states or provinces and the federal governments are true masters of their own domains. And so that's what Canada is. And as I'll get into, healthcare seems to be primarily something for the provinces, and so is public health. Municipalities are literally the creations of provinces. The regions in Quebec, other sub-provincial boundaries, are really things that can be created or destroyed with the stroke of provincial legislation. Indigenous persons in the First Nations of Canada, as well as the Inuit and the Métis in Canada, have increasingly some jurisdiction for health and public health. So, and what we're seeing with the public health within First Nations Health Authority in BC, the only jurisdiction where it's been at the province fully devolved, the control by Health Canada for First Nations health care, that we're seeing the development of public health within Indigenous communities, and that's going to be something that's going to be happening more and more. So there's really 3 jurisdictions for public health in Canada, or multiple, considering that there are 10 provinces and 3 territories, and multiple First Nations, Inuit, and Métis communities. The federal government divides its claims to jurisdiction from authority over criminal law, peace, order of good government, Aboriginal health, quarantine, the military, federal prison, citizenship, patents, international treaties, and its ability to spend its money as it wishes, so-called spending power like Medicare. The federal government can sort of bribe provinces to be in different areas, do different things by holding out money, but it hasn't done that much recently. Next slide, please. That in general, and this is from a book written by lawyer Martha Jackman, who highlights that the provinces have been seen as responsible for most of what we consider public health through their authority over local matters, as well as property and civil rights. So this means that actually, even though that you can make a pretty convincing case, I think, for federal public health to be more involved, for example, in collecting national statistics, that the federal government has not got jurisdiction in that area. It does have to work with the provinces, usually with cost-shared agreements, to even get national statistics created. Next slide, please. And there's a lot of different models, just as we saw the differences in BC and Quebec, but all provinces have some sort of provincially based centralized services, a chief medical officer of health office, and more regionally and or locally based services. Ontario stands out for retaining municipal-led public health. Most public health in Canada was municipal up until about the 70s. And over time, that public health was integrated into the healthcare systems of all provinces but Ontario, where municipalities still have responsibility for delivering public health. Public health local level is delivered through 36 different public health units in Ontario. That in most other provinces, like in Quebec, local public health is integrated into either regional authorities and or local authorities, or both, as Quebec used to have, and or provincial authorities. And so, for example, Alberta, New Brunswick, some other provinces did have regional health authorities. Now there's only provincial health authorities, somewhat at arm's length from provincial ministry of health. And there are very different relationships in different provinces. Next slide, with different services that are covered. And I've given you a website that's maintained by the National Collaborating Center on Healthy Public Policy, which is a wealth of material on the organization of different public health functions in different provinces. I should say, and this is no criticism, there's so much to get done, not always, then I will be wrong, 100% up to date. Some of the new Quebec reforms or deforms, for example, are not in there, maybe because they're not final yet. But that in general, this is where you should go, as well as talking to colleagues across the country to find out how different issues are dealt with. Next slide, please. And next slide shows some different scenarios that I threw out just to get people primed if you need to, be primed anymore to think about things. But these scenarios would involve public health to a lesser or greater extent in different jurisdictions. And this is, and we could have an interesting dialogue if we had more time. Yet one of the more senior people in a few jurisdictions to just go through in turn how this would be done in their jurisdiction and see how differently it would be done, and how differently the federal government would be involved or not involved, depending on various aspects of these scenarios. Next slide, please. That's really it. And that's really it. We don't have
Great. Thank you very much, Michael, and all the other speakers. I think we have about 15 minutes left for questions. And I see that some questions have started to populate the chat box. So please, now is still time to get in your questions. So I'm just going to start. I'm actually going to start with a question about health and all policies. And I guess any of you can answer it depending on. So if you could unmute all your microphones, that'd be great. Is there any evidence that health and all policies in Quebec or anywhere else, has improved the health status of its citizens? Anyone want to take a stab at that one?
Dr. Guyon, Michael Rachlis. I was going to suggest that Dr. Guyon start, but I have a comment as well.
Yeah.
This is Ak'Ingabe.
There has been great accounts
done by the. Sorry, there's a lot of reverberation. There have been great accounts done by the National Collaborating Centre on Healthy Public Policy on the Quebec experience with health impact assessment. So I won't substitute my voice to their senior voice. But yes, health impact assessment processes are undergoing within the health ministry. They are mediated by the Provincial Public Health Department interacting with other ministries. However, these have been ministerial processes, this health impact assessment article in the public health law. These are not required at the regional or local level. So when we do health impact assessment at a regional or local level, we do it out of the medical officers of health duty to inform the population of the health risk, etc. So evidence on whether it's worked on the health of people, I think the evidence that is there is on the quality of the processes that have been going on. And I'd really refer you to, if you just type on Google Quebec Health Impact Assessment and the National Collaborating Centre, you'll find good accounts of what are the positive aspects and negative aspects of these processes. This is as best as I can do, Gia, to link health impact assessment to health outcomes, which is a difficult link to make.
No problem. That was great. And then, Michael, you said you had a comment as well.
Yes, that I've done a fair bit of reading on this over the years and talked to people, and my understanding, just as an example of the barriers to this, is that probably there wouldn't be even the ability through so-called, I think it's sections 54 and 55 of the previous law to allow the health impact assessment by public health. There probably is only that allowance for that in Quebec because it has already a society where planning is much more intersectoral. And the Quebec ministry is not just a ministry of health, of course. It is an integrated ministry of health and social affairs, which I think denotes a much more, European, if you will, values of Quebec society and approach to intersectoral planning. But even in Quebec, the health impact assessment, I agree, Dr. Guyon, she's suggesting it is something that Quebec Public Health is mandated to do. The other ministries do not necessarily have to follow exactly what health says. And, for example, the Ministry of Finance early on said that they would not really be subject to these health impact assessments. And given that most really fundamental legislation goes through the Ministry of Finance, this was very much a signal by the Finance Ministry that they felt that economic lens, if you will, was the key lens for overall government planning and intersectoral planning. So I think that my assessment of literature is that that sections 54 and 55 have had some impact to leading to more intersectoral planning, but Quebec is already primed to be doing it.
Great. Thanks, Michael. So we have a lot more questions now, so I'm going to combine, there's two questions surrounding HR. One is, to what extent are public health skills transferable, and what role do public authorities play in training the health workforce? Maybe I'll direct those questions at Dr. Allison, because I believe you trained not in the jurisdiction you're currently working in.
Yeah, thanks, Ja. So I did train in Manitoba, and I did transfer as a public health physician to northern British Columbia from 2014 till 2016. I've been here, and I would say that overall there are some adjustments. Obviously, given the variation province to province, that you have a learning curve for your system, but all of the key public health skills and competencies that are gained in training are definitely transferable. There was also another question about trainees, and maybe I'll address that as well. Not just trainees, but about how do health authorities get involved in training. I've had many master's students come through here in 2 years. We're always very happy to have students come and work on different areas of work in our regions, and so I think that is the training ground for many trainees in public health. That's it, Joe.
Great. Thank you very much. Okay, moving on to more questions, which is great. So we have a question on, will we see a return to a focus on municipal public health centers in Ontario, or are things working well since the integration? I guess I'll direct that one at Michael.
Sorry, I should clarify and I hope somebody can deal with the feedback that I'm getting here, but I hope you're not getting it. That there was in a discussion paper that the provincial government put out a suggestion that public health funding would go through Ontario's regional planning bodies, local health integration networks, they're called. They're not really like regional health authorities in that they don't deliver any services. They're funding bodies, but they're regional funding bodies. That there was a suggestion that public health funding would go through these organizations, which are primarily funded for health care. But ultimately, the provincial government legislation did not have this. The legislation is going to be reintroduced shortly because the provincial parliament was prorogued. There's a new solution to the throne. All the new legislation will have to be reintroduced again. But it may happen through regulation because the new legislation will allow this through regulation. But it still is not official that municipal public health would be integrated through the local health integration networks or healthcare system in Ontario. Now, if there's anybody else senior from Ontario has anything different, please type it in. But so far, it's still a live discussion, a very good one we can still have. We should be thrilled that we've got variation in Canada, so we should be able to learn something. We've got a number of different models across the country, including municipal public health in Ontario and different models in Quebec and BC and some other provinces. So we should be able to learn something, but ultimately we have not really found that there's a perfect model.
Great, thank you very much, Michael. Okay, moving on then. We have a question, and I'll direct this one to Ak'Ingabe. Well, actually to all speakers, so all three of you can answer, because I think this is an important one. So how do you advocate to various levels of government to improve public health funding and increase interest in public health in general without, say, having another SARS or another Washington, which seems to be the primary impetus for public health funding, at least from my personal observations? Do you want to start, Ak'Ingabe, and then we'll go to Sandra and then Michael?
Thank you. I think there are different levels of advocacy that need to happen, and we're not that active at some of these levels. One level is actually the constituency level. I think that elected officials need to understand more what is public health, what are public health activities, and it's an uphill battle. We're in competition with so many other services and so many other industries that are trying to reach elected officials for them to know what is their line of business. But still, we've had some experience around the cuts, but there have been also great experiences in public health across Canada with the tobacco work that has been done over decades, where approaching elected officials in informal or formal visits to know what are their preoccupations and interest them to the public health successes that they can talk about then or be aware of is relevant. That's one level, and I think each health professional and even at the citizen level that can be done. Then there's the public health organizations that I think need to continue to try to, looking for the word in English, but to rayonner, to show what they're doing. And that's a constant battle because we're stuck into delivering not stuck, but we have to deliver frontline services, yet we should be showcasing what we have to do, what we're doing. And then there's this third level of advocacy that provincial or pan-Canadian organizations can do, such as CPHA, or NGOs can do. And the more you have organizations that are dedicated to public health, I guess the more focused this representation of what public health does will be strong. And there were some examples in Quebec, as I mentioned earlier, Jeunes Médecins pour la Santé Publique or Mouvement Citoyen pour la Santé Publique, professional and citizen movements. I'm in conflict of interest. I was part of both. I am part of both, but whether they've been successful, I don't know, but I think it's key to have those voices talk about public health.
Thanks, Ak'Ingabe. So I just would like to add the levels are excellent, and another layer to the how is actually with data. So I'll give you a very specific example. When I started in Northern Health in 2014, there was a referendum with the municipal government changeover in our province, and the city of Prince George voted to remove fluoride from our water. That was taken effect almost immediately after the election, and so for the last 2 years there has not been fluoride in our community water system. And our work here is important to just keep track of the impact of that decision and then return to them in a few years with evidence of the experience perhaps in Edmonton and Calgary, and then what we're seeing here with our young children in our dental screening clinics. And use that data to inform and hopefully persuade a switch to scientific-based decision-making rather than emotional. And I think that is something that we need to do in a careful way that's educative, as well as partnership building and building trust. Now, other jurisdictions have done away with municipal decision-making. I think I'm reflecting on New Zealand, where they've relieved the municipal leaders of making those decisions and landed them within health, which is a better place. So anyways, that's just one example of advocacy and the way to do that based on evidence.
Michael Rachlis, just very briefly, because this is like 1,000 hours of study to answer this question properly. But very briefly, I think that public health is uniquely placed to be an effective advocate, but it needs to do two things. One, we need to take advantage of the fact that we're part of the state as public health services. And if we're fortunate enough in Quebec and some other places to have a position at the Executive Committee of the Ministry of Health, or to be able to advocate directly at the cabinet level, then we have a role there within the structure of government. But then we have to ensure that we are facilitating, usually by others, the mobilization of constituencies and communities and citizens to actually make the difference. And that's what I think Ak'Ingabe was partly referring to in the work that they're trying to do in Quebec right now. But if you don't have the Mothers Against Drunk Driving, if you don't have the Non-Smokers' Rights Association, you're dead in the water at dealing with alcohol and tobacco control issues. So, and the strength of the Vancouver Union of Drug Addicts, for example, drug users rather, to help advocate for supervised injection facilities and other harm reduction reforms. So it has to be both take advantage of being part of the state, which is what we are as formal public health services, to be able to speak truth to power and work within the power, but we have to be connected, even if it's indirect, with communities to make sure they're being mobilized, because that's where the real power comes from.
Great, thank you very much. So we just have time for one last question, and I'm going to direct this one to Dr. Allison. And this is to explain a bit more about the First Nations Health Authority in BC and its relation to other provincial public health and health structures.
Thanks, Ja, and thanks for the question. I mean, it's really a complex question, and I don't think I can do justice to it in 1 minute, but I will try my best. I did not dive that deep into the details around First Nations Health Authority for the main reason that I'm probably not the best person to speak about their organization. So I will just put that as a disclaimer in front of what I'm going to say. So in 2013, the organization was formed as a result of a tripartite agreement amongst the federal government, Health Canada, the provincial government, Ministry of Health, and the regional health authorities. Between each of the health authorities and the First Nations Health Authority, we have a partnership agreement, and that partnership agreement does guide our work, and we have a work plan that is informed by this partnership agreement and driven by priorities that were defined by community. So there is some, just I would say, growing pains related to how the organizations are working together and how we connect to pick up the pieces of where Health Canada and FNIHB left with services. Now I do understand there's still some connections with FNIHB to those communities, maybe the non-insured health benefits, but really, like I said, that's going way beyond my level of detail that I know. The Chief Medical Officer for the First Nations Health Authority is Dr. Evan Adams, and he connects very closely with the Provincial Health Officer, Perry Kendall. There's a memorandum of understanding between them, but I don't know the details of that. So I think I'd like to stop there. That is a minute flyover First Nations Health Authority and probably worthy of a teleconference or a webinar.
All right. Thank you very much. That's all the time we have for questions. But if there are any unanswered questions left in the chat box, I believe CPHA will email you and answer the question for you, which is an excellent level of service. So actually, before we wrap up, I just want to say a big thank you to all the speakers and for all the questions. And I'll hand it over to Ian again to close for us.
Thank you very much to John and all of our presenters. Great job today. A lot of material covered in a very short period of time. Specifically on the question about the First Nations Health Authority, please check out their website. They have quite a bit of detail about how they're structured, how they came to be, and how they interact with the other levels of government. So that's a great place to start if you're interested in that. So very quickly, November's webinar is on the topic of getting a job in public health with an MPH. So registration is open, and you can check out that link on CPHA's website. So do check that out. And just finally, there is a call for submissions for the Student and Early Career Professional website that's part of CPHA's website. We're looking for commentary and opinion pieces on a range of different topics. So if you're interested, check out the information, which we will circulate, and you can contact students at cpha.ca for more details. Once again, thank you very much to everyone. The recording will be posted on CPHA's member portal in a couple of days, and you will receive an email with information on how to access the recording. Hopefully this was a productive session for everyone, and we look forward to seeing you next month.